Good morning, and this time I have got the Phenylketonuria in Pregnancy Talk article summarized for you. I hope this will help with your revision of your upcoming exams. And if this video is useful, then don't forget to give it a thumbs up and subscribe to my channel if you haven't already. So phenylketonuria is a deficiency of the liver enzyme phenylalanine hydroxylase. The phenylalanine hydroxylase converts the amino acid phenylalanine into tyrosine. It's the most common inborn error of metabolism. There's a screening program for it which helps detect it quite early on, as if it's detected early and treated early, then the outcome is much better. The primary treatment involves a low phenylalanine restricted diet. Um, it's an MDT approach in treating the patients, which includes a dietitian, a biochemist, chemical pathologist, clinical nurse specialist, physician who is experienced in metabolic diseases, an obstetrician, a GP, a social worker, and a clinical psychologist. Untreated maternal fetal phenylketonuria or hyperphenylalaninemia during pregnancy can result in in utero growth restriction, low body weight, microcephaly, congenital heart disease, intellectual or developmental disabilities, facial dysmorphism, and rash. So it's an autosomal recessive condition. It's in phenylalanine hydroxylase deficiency results in toxic levels of phenylalanine in blood and a potential tyrosine deficiency. Tyrosine is a proteinogenic amino acid. It's involved in signal transduction processes in the body. Tyrosine is high in protein-rich foods like dairy, chicken, fish, eggs, beans, oats, wheats, and nuts. Buildup of phenylalanine is toxic to the brain and it alters the myelin synthesis. So it's recommended to follow the dietary restrictions during the first 5 to 6 years of life when brain growth is the most rapid. Incidence of phenylketonuria is 1 in 10,000 births in the Caucasians and East Asians. Phenylketonuria is rare in Africans. The ethnic groups with high incidence include Turks, the Turkish, the Irish, and lower rates in Japanese and the Finnish. So, classification of phenylketonuria. So, normal phenylalanine levels are less than 120 micromoles per liter. Classical PKU is phenylalanine levels of greater than 1200 micromoles per liter, or there's a complete or profound absence of phenylalanine hydroxylase activity. Non-classical PKU, which includes mild to moderate and hyperphenylalinemia. Mild PKU occurs when phenylalanine levels are between 600 and 900. Moderate is when phenylalanine levels are between 900 and 1200, and hyperphenylalinemia is when phenyl levels are less than 600. Patients with hyperphenylalinemia have less severe accumulation of phenylalanine. This is often managed through monitoring and little dietary restriction. Untreated or suboptimally treated women with phenylketonuria have elevated phenylalanine levels that are teratogenic to the unborn fetus. Phenylalanine is actively transported across the placenta, reaching fetal concentrations that are 1.25 to 2.5 times greater than the maternal concentrations. Clinical manifestations include in utero growth restriction, microcephaly, congenital heart disease, and fetal dysmorphism. So it can be quite difficult to distinguish between fetal alcohol syndrome and phenylketonuria. Older untreated children with PKU have microcephaly, epilepsy, musty body odor caused by buildup of phenylic acid in the urine. decreased skin and hair pigmentation, eczema, severe intellectual disability, and behavior problems like hyperactivity, problems with language, memory, and attention. MRI can help visualize structural brain damage in both maternal phenylketonuria and fetal alcohol syndrome. A dose-response relationship exists. The greater the exposure, the poorer the outcome. In both syndromes, so you have fetal alcohol syndrome and PKU, microcephaly, facial dysmorphism, and growth delays generally improve with time. Tyrosine is also required for melanin production. Therefore, children with PKU who lack tyrosine tend to have blue eyes and are fair-haired and fair-skinned. In phenylketonuria, developmental neurotoxicity can occur because of in utero fetal exposure to high phenylalanine levels. Damage caused to the fetus by mother's high phenylalanine levels is reversible. The treatment of phenylketonuria is a phenylalanine restricted diet, restricting intake of protein-rich foods, recommend intake of amino acids in diet without ingesting excess levels of phenylalanine, supplementation of liquid formula containing protein, hydrolysates, or free amino acids. Phenylalanine restriction can be challenging for adolescents and young adults who left family home, and they often choose to stop complying with this diet. Discontinuing dietary therapy after adolescence has no reported serious adverse effects on the nervous system, and as a result, strict dietary control is often not maintained after the age of 17. Continuing diet after this time appears to be beneficial. Loss of IQ and/or behavioral changes have been reported in older children and adolescents who did not adhere to the diet. These changes are reversible with resumption of diet. So preconception, the outcome is improved substantially when treatment results in low maternal phenylalanine concentration, ideally before conception or less optimally before 10 weeks of gestation. Women in reproductive age who have grown up with phenylketonuria have discontinued their phenylalanine restricted diet by that time. Contraceptive choice essentially unrestricted. Combined oral contraceptive pill has an advantage over the mini pill because presence of regular periods, which if missed would indicate the possibility of an unplanned, undiagnosed pregnancy. The oral contraceptive pills should be switched to a barrier method of contraception at least 3 months and ideally 6 months before conceiving. This allows the menstrual cycle, which may be altered by the combined pill, to revert to normal. Folic acid supplementation should be recommended. The target blood phenylalanine levels should be kept low, ideally between 120 and 300 micromoles per liter. As if they were following a low phenylalanine diet. The European phenylketonuria guideline has recently recommended a blood phenylalanine level of 120 to 360 in order to achieve this high degree of control. Significant commitment is required by the women, and support of the multidisciplinary team must be unwavering. Preconception maternal phenylketonuria program entails reduced natural protein intake or protein exchanges plus extra phenylalanine-free protein supplements to lower phenylalanine levels. This can be particularly difficult in classical PKU. Twice weekly blood spot monitoring is required. Dried blood spot specimens are collected by carefully applying a few drops of blood freshly drawn by finger stick with a lancet from adults or by heel stick with a lancet from infants. 3 to 4 bloods with phenyl levels of less than 350 is considered safe for them to have unprotected sexual intercourse to start trying to conceive. If they fail to get pregnant after 12 months, some may consider consulting a fertility specialist, as adherence to the low phenylalanine diet for more than 12 months can prove to be a challenge. So antenatal care, you want to provide a multidisciplinary team team approach. Nutritional guidance is absolutely essential. In first trimester, there may be nausea and vomiting, which may complicate adherence to the low phenylalanine diet. So admission to hospital is one of the options to ensure phenylalanine levels are controlled and the diet is adjusted accordingly. Blood phenylalanine levels are measured 2 to 3 times per week during the pregnancy, and profiles of amino acids, vitamins, minerals, and trace elements, and full blood count measured during the dating scan and the 20 to 22-week gestation. Essential amino acid tyrosine is required in supplementary form after 16 weeks of gestation. Most fortified supplements include various vitamins and minerals, but they should be taken in caution to prevent excess of, for example, vitamin A. When blood phenol levels cannot be brought to within normal limits, especially in early pregnancy or unplanned pregnancy, additional phenylalanine-free protein supplement can be introduced to reduce the levels. Energy requirements remain unchanged in pregnancy, so expectant mothers should gain no more weight than is appropriate for normal pregnancy. Additional ultrasound surveillance is recommended and is offered following MDT management plan. Ultrasound in first trimester helps with screening and can identify non-viability, which in turn prevents needless continuation of the restrictive diet and associated costly metabolic serum monitoring during the pregnancy. Second trimester, ultrasound can pick up congenital abnormalities. A fetal medicine scan with a fetal echo is recommended between 20 and 22 weeks. Risk of congenital heart defects is 7 to 10%. Serial growth scans are recommended to increase as there is increased risk of in utero growth restriction and microcephaly. It's difficult to detect microcephaly and diagnosis is usually made at 28 weeks. Microcephaly is diagnosed if the head circumference falls 2 standard deviations below the mean for gestational age. Definitive diagnosis of 5 or more standard deviation below the mean just confirms and is a definitive diagnosis of microcephaly. Delivery and antepartum, so timing and mode of delivery is guided by the obstetric indications. Breastfeeding is safe and encouraged. Breast milk contains low phenylalanine concentrations than most infant formulas. Reduced phenylalanine formulas is available if needed. So postnatal metabolic consultant review is required approximately 3 months postpartum. Neonatal examination to assess clinical features of PKU. Neonates born to mothers with PKU should be offered the PKU screening on day 5 as per routine national screening program. It's recommended that a clinical psychologist conducts assessments at 18 months, at 4, 8, and 14 years to identify any developmental or cognitive problems and suggest any additional educational support if required. Unplanned pregnancies, the fetus is exposed to high phenylalanine levels which can be teratogenic. Education and psychological input is required. Assess access to a clinical psychologist, provides patient with support needed to maintain a low phenylalanine diet as an adult, ensures a woman's emotional well-being, and offers support to the family. GP is an important link between the MDT and the patient and provides the much needed support and reassurance. So this is just a little diagram which shows the oxidation reaction of phenylalanine to tyrosine pathway. So you've got your dietary protein, phenylalanine, you've got your phenylalanine hydroxylase, which converts it into tyrosine, which is then converted to dopamine, melanin, and other body proteins. So that's quite an important diagram, as you can see how important tyrosine is and how important is this enzyme here that helps to convert this phenylalanine into tyrosine. Well, that's it. I hope you found this summary useful, and if you do, don't forget to give this video a thumbs up and subscribe to my channel if you haven't already, and good luck with all your upcoming exams.